You know, when I was 18 and a potential alcoholic, thinking about how I could earn beer vouchers, and you'd said to me one day, you know, I'd be stood here lecturing to a load of people and being able to do X, Y, and Z, I wouldn't have believed you. But that's how fantastic podiatry is. How many people here are podiatrists? Oh, you. How many physios? I know there's at least one. So good physios. Anybody I haven't thought of? Any chiropractors or any? Osteopath. I was getting on to osteopaths. C, O, alphabetical, keeps it all fair. You know what? Podiatry, one of the great things about podiatry is giving me the opportunity to lecture not just in the country but around the world. And I have to tell you, our knowledge base as UK podiatrists in terms of conditions and treatments is not perhaps as good generally as it could be. But of biomechanics, I haven't met any podiatrists around the world that are better generally than we are at biomechanics. And I'd say that particularly in America. I mean, there are some fantastic biomechanists, we know that. But the general knowledge base is not particularly good because they've gone surgical. They've gone stick a needle in. That's quick, it's easy, we can fix it. We're really good at biomechanics, right? But we have to look at the evidence base to guide us about where we go because we're still using some old theories. And one of the problems with research is it tells you what you can't do. Right? And everyone will say, you look at research, you can't do that. We proved that that doesn't work. That's not repeatable. You can't do this, you can't do that. Well, I work in clinic. And when I've spent half an hour telling my patient what I can't do, she says, yeah, you know, my foot hurts, so what can you do? I suppose I'll go back to what I always did. Right? So what I want to do with my two lectures, I'm going to talk around a couple of conditions, but I'm going to intersperse with that some biomechanical theory and about how I just think about biomechanics at the moment and how some of the research ties into it and perhaps where we can go with it. So, I'm going to talk to you first of all about Achilles tendonopathy. Always have to remember the anatomy. That's one thing we're not good at. I had a guy come in, he wants to update his knowledge and be able to do ankle blocks in clinic. I said, fine, come and work in my surgical service. Do ankle blocks every week. We'll give you the experience, you can do it. So I said, you need to watch a few, you know, maybe do a couple of supervised and then you can do them yourself. After 3-4 weeks, he says, I'm ready, let's go. I said, all right then, just tell me about the anatomy around the ankle then. What are the tendons on the medial aspect of the ankle? And he goes, extensor digitorum, and I went, whoa. Extensor, what's that mean? What does that do? He went, what do you mean? I said, well, extensor, what's it do? And he really struggled with the anatomy. He didn't know the anatomy, right? And if I said to you, tell me the structures on the medial aspect of the ankle, and you can't just reel it off, you don't know your anatomy. And if you don't know your anatomy, you can't treat anybody, because you have to know your functional anatomy. The best way to learn your anatomy is when you're with a patient, they've got pain somewhere, get out the anatomy book, pretend you're educating them. Right? Let me just show you the structures on the inside of the ankle. Thank God for that. Right? And you know what? Now, we've got all these digital anatomy programs that are fantastic. The patients think you are the dog's knackers. Right? You've got to know your functional anatomy. If you don't know your functional anatomy, that's where you'll learn from the physios. The physios' anatomy is fantastic. No one knows it like the physios do. Okay? We should know the foot. We are the experts in the foot. And if you don't know your anatomy, get back to your anatomy books. So, we've got the Achilles tendon, gastroc and soleus. Come on, yeah, we know that, Trevor, right? Yeah, and they merge at the musculotendinous junction. Did you know that the fibres rotate 90 degrees before they insert into the cow? They do. That's pretty weird, isn't it? So when we do an Achilles lengthening, we do it in one plane, but the fibres rotate. And we wonder why it doesn't work. The plantaris sits on the medial aspect and inserts into the medial aspect of the calc. Were you aware that the plantaris is stronger than the rest of the Achilles? So if that's tight, the rest of the Achilles is tight. There's an orthopaedic surgeon in London, it's a foot and ankle specialist. He has a small subset of patients who have a plantaris problem, and he releases the plantaris tendon. That's a thoughtful orthopaedic surgeon. Right? There's lots out there that we don't know and we don't appreciate, yet we think we can treat everybody. There's a bursa that sits in here. Yeah, you know there's a bursa. Do you know how big it is? It's actually quite big. And you know what? On the underside of the Achilles and on the back of the calcaneus, there's a fibrocartilage, just like a joint. Similar to the peroneus longus, as it goes underneath the cuboid, there's fibrocartilage there. It can act like a joint. You can get a synovitis there. Right? There's much finer anatomy going on than we appreciate a lot of the time. The fascial cura or the cural fascia, that's the compartments of the leg as they go round. So when you get your joint of meat, a bit of beef, and you open it up, you've got that thin gossamer, that's the fascia that keeps everything bound down and it attaches to the bone. That comes and it joins into the paratenon. Right? The paratenon is the, I don't really need to tell you that, but instead of having a tube tendency, you have the paratenon. They merge here, and then the paratenon takes the rest of the way down. Well, you know, when you look at any kind of condition or any kind of pathology, if you don't know the anatomy, you can't start to understand the types of problems that you're treating. And everybody talks about this zone of hypervascularity. We know that tendons don't have a direct blood supply. We know that the blood supply is not good, therefore they don't heal well. Right? For the Achilles tendon, the blood supply actually goes into the paratenon. But how good is that blood supply? Well, nice little study, just been published, looked at blood supply on cadavers by doing angiograms. And what they found was both the tibialis anterior and the tibialis posterior provide vessels that supply the paratenon. But when they dissected them out, they couldn't find the ones from the tibialis anterior because they were too small. But they could find the ones from the tibialis posterior. So there's lots of blood getting into that paratenon from all over the place. Yet we call it a zone of avascularity. That will become relevant when we talk a bit more about pathology. I had to put a slide in about etiology. When anybody comes to train and do their surgical exams, I say to them, okay, you know, any subject, you know, it's pathology, etiology, clinical features, da-da-da-da. If you know all of that about every condition, you can answer a question. If you don't know each little bit, you can't answer it. Right? Larry Harkless, who's an American podiatrist, who's kind of one of the people that has always inspired me, has a great saying, and I always get it wrong, but I'll try and get it right. And he says, you look for what you know, and you find what you look for. All right? So if you don't know it doesn't exist, you'll never look for it, so you'll never find it. All right? So you have to know all the conditions that can be there, so that you have the chance of being able to make the right diagnosis. And if you've ever treated a patient with an orthotic or anything, not really knowing what the diagnosis is, you haven't done that patient a service. Because you must know what you're treating to be able to treat it. Because you need to know whether an orthotic is going to work. A great example of that is chronic compartment syndrome, where you get exertional leg pain. Nat Padiow, good friend and colleague of mine, has demonstrated orthotics have no influence on the compartment pressures. Therefore, if you don't know you're treating that, and you give them an orthotic, it's never going to work. So you have to get a diagnosis. So I have to put etiology, idiopathic. Always put that. Why? Patients say, why did this happen to me? Sometimes we can find a reason, and sometimes we can't. So what do I say to that patient? I swear on my life, I go, you know what? Shit happens. I don't know why you had it, but you've got it. And now your foot's doing this. But why has it happened now? I'm 45. I said, well, you know what? I ate fat for 30 years and now I've got blood pressure. You got older. You can't cope with it as well. Things just happen. Overuse. I'm just going to run through because... Except ciprofloxacin. You can get tendon problems because of ciprofloxacin. So you need to screen. You know, I had a patient, this is where weird things happen. I've opened a foot up to a bunion operation, the bone's black. I'm like, oh, I've never seen that before. I've never read anything about that before. What do? Get me on the phone, I'm all scrubbed up. Who's in the hospital? I'm like, I've got this patient, he's got black bone. I don't know. Right, okay, well, I've taken take that bump off, we can send that test, I'll close it all up. Sent it off, came back, suggested it was bone bruising. I'm thinking, I've got to write that one down. I saw a paper 2 weeks ago, talked about black bone disease, rarely reported in the foot, and they showed an example of it. And they allocated it to tetracycline use, staining the bones as it can do teeth. So I'm like, ooh. I said to my secretary, ring her up and ask her if she's ever had tetracycline. My secretary said, yeah, she had 6 months of it when she was a teenager. How weird is that? So I could have operated, and so I did her other foot, opened her other foot, black bones. Exactly the same on the other foot. How weird is that? So I'm not going to teach you to suck eggs, but the way I look at biomechanical theory, we've got a traditional root weed, I call them root creep and latent orient, right? Everybody slags it all off, but there's still a fundamental underpinning because no one been able to replace it. There is so much of what I'm going to say that overlaps with what Brian said. Right? I was smiling all the way through your lecture. Brian, let me just offer you one thing. the ADs, which are the stretching board that we have here. Here's how I test for Achilles inflexibility. Stand on this slope. If you can stand upright, you're fine. If you can't, you've got a problem. You know what? The patients get off and go, your calves are tight. Let me try that again. No, no, no. You didn't do anything wrong. You can't do it. Oh. Right, okay. So when they go and stretch and you come back, they kind of sat there and they're looking at the corner of their eye, seeing the stretching board there, and they either want to get on it because they want to show you how good they are, right? Or they go, oh, I haven't really stretched. Go on, get on, show, oh, you see, you still can't do it. Right? Great way of doing it. So I get them to make it up themselves with a breadboard and a phone book and all that kind of stuff. FHL, I'm not going to talk to you about FHL because Howard's here to do it, you know it all. Suffices to say this is a Premiership and England football player that has classic FHL, but he can play Premier League football. Right? We can cope around it. When they get the injuries, I remember assessing a Premier League footballer. The physio said to me, have a little look at this guy. This guy's like this. Right? And I'm like, oh. I said, Bob, forget it. We're doing nothing. Just pray he never gets injured. Because if he gets injured, now you've got a nightmare. And this guy had a stretching regime and a strengthening regime that just kept him going. And he was a mechanical mess. But he's fit. These guys are so fit, they can overcome a certain amount of imbalance. And we see that with the pressure analysis. I could take a patient that's got a leg length discrepancy and everything's all over the place. But these guys are super fit. They can control it so well, you see much less imbalance. Kirby talks about the subtalar joint axis and how it can be deviated. Well, I have to tell you, I have assessed it over the years. I've stopped assessing it. I don't know if I've ever seen a laterally deviated axis. I've seen loads of medially deviated axes. And before they stand or I assess them, I can tell it's medially deviated because they've got tibialis posterior tendon dysfunction. I like the concept about how you control the foot, but I'm not convinced. I think it's cause and effect. But hey, then there's tissue stress, which is more or less the same. But tissue stress to me is it hurts here. Who's it? A really good friend of mine spent a few months with Lowell Weil, who trained with Steve Subotnick, who, you know, if you're an older podiatrist, Steve Subotnick was one of the guys that started biomechanics and sports biomechanics. And he told my mate Gary, he said, yeah, I trained with Steve, and one day, he said, I looked in his shoes, he had a pair of orthotics with some felt stuck on them. And he said, Steve, you do all these orthotics, what's that bit of felt stuck on your orthotic? And he said, well, one day it hurts here, so I put a bit of felt here. Next day it hurts there, so I put a bit of felt there. I'm like, oh, you can't. That can't work. How can I do that to a patient? Tissue stress to me is it hurts here, you unload it. Is that normal function? To me, our aim has always got to be is to get a patient as close to what we believe normal should be. And notice I said that very carefully because we don't really know what it should be, but as close to structurally normal as possible. That should be your first point. If that doesn't work, then you start compromising your control to get them symptom-free, because when we compromise the control, we don't know what we're causing somewhere else. Because if we give someone a massively inverted orthotic that really blocks up their foot position and their foot feels great, how do we know that in 15 years when they get their back pain, it wasn't because of the orthotic? They'll never put it down to their orthotic. All right? Similarly, when someone does a bunion operation and shortens the first met by 2 centimetres, and they come back 2 years later with a straight toe that doesn't hurt them, but they've got second MTP joint pain, they haven't related that to the bunion operation because that worked. That was 2 years ago. Right? You've got to think about where you might take someone. And then proximal dysfunction. I'll go into this. I think our skill as podiatrists should be determining whether it's the foot or outside the foot that is causing the problem. And I'll give you some guidance later on how I think we can do that. So if we look at foot motion, Chris Nestor did a nice review and he showed that there were joints in the foot that move as much, if not more, in the frontal and transverse planes. Furthermore, all of the joints of the foot demonstrate triplanar motion. What's more, where it moves and how much it moves varies between us all. Right? We can't just say it's the subtalar, it's the talonavicular, it's the navicular cuneiform. It varies from individual to individual. And when we run, everything stiffens up and it moves less. But we think we've got to give them more control. How does that work? You put more control on because you're running and the joints are moving less. Maybe we need less. I always say to people about control, whether you jam it up or you make it flow. If I try and punch someone and I do it slowly, they have to use a lot of force to move my hand out of the way. As I swing a punch, you deflect it. So when you stand someone on an orthotic, you've got that slow punch, a lot of force. You need a lot of force to change motion. But when you're walking, you need much less because you just have to guide it in a certain direction. That's facilitation, right? Because that's why if someone stands on something, it's a small stone, at the wrong time, the foot goes over. Why do people fracture dislocation of the ankle? They only went down 2 steps. Why? Timing. Anybody plays golf, you hit the ball just right, it flies. You hit it wrong, your elbows, your shoulders, everything hurts. It's all about timing. So, what I think, and this will tie in kind of what Brian was talking about, but slightly different. I started thinking about the movement of the foot. So, we've got a pronated foot that's mobile. We all see that. That's the more hypermobile foot. But I see pronated feet that are stiff. Classically in Afro-Caribbeans, we have a lot of those in Hackney. All right, they have a naturally flat foot, but it doesn't move too much. It's a bit stiffer. Then I see people that are unstable. So this patient on here, this is a flat foot that's rigid in the middle, but unstable at the ankle. This is a flat foot that has metatarsocuneiform instability. It's too mobile. We take our supinated foot, we look at them on the couch, that looks like a supinated foot. They stand down, it pronates, because they've got mobility. Conversely, here's the stiff version. Now it's a supinated foot. And then we can get the instability. So this one, it's really stiff, it's all lateral, they have a tendency to go over on their ankle. This one's buggered it's the same foot, if you haven't noticed, because I cheated. Now they've buggered all the ligaments, now it's unstable. So it's too mobile. So I look at my patients and say, what's your foot type, what's your mobility, where's it moving? As it becomes stiffer, my orthotics become more accommodative. As it's more mobile, they become more controlling, with various factors built into it. Commonly, in Achilles patients, I don't see many Achilles patients with feet like that. I see much more like that, right? And they are the ones that need sagittal control. So, what about the pathology? Peritendinitis, so you can get a little bit of inflammation around the peritendon, or tendinosis, where the tendon becomes thick, or you can get fluid within the tendon. Those of you used to looking at MRIs can see this patient's also got a little bit of a ganglion at the back. That's the most common Achilles pathology that we see. And when a patient comes in and they've got this, I'm far happier than if they come in with an insertional tendinopathy. These are much more difficult to treat. Fortunately, they're less common. They often have a spur. If you look at this ultrasound, if you're not used to them, we're looking kind of sideways. So the Achilles here, the plantar aspect of the foot's here. That's the Achilles tendon. Look at, you've got bony bodies in here, and this is all spurring. Okay? Fortunately, that's less common. And you can get bursitis. So the bursa becomes inflamed. Often, it can occur in isolation, but often it occurs with other pathology. And obviously, it causes rupture. Ruptures are acute. I don't see many ruptures. I'm not really going to concentrate on that today. Alfredson and his group in Scandinavia looked at neovascularization. And what they found in patients with painful tendinopathy is that if you look at them on ultrasound, they have this increased blood flow around the tendon, into the tendon. And the concept there is that the body's trying to heal the tissue, so it puts neovessels into the area, and they take nerves with it, and it's those nerves that cause the pain. And therefore there's a whole treatment regime around trying to stop the neovascularization to stop the pain, which we'll talk about. In fact, I think Achilles tendinopathy is one of the few areas where we're beginning to have a good, and patella tendinopathy, these kind of tendon pathology, we're beginning to get good information and being able to develop some good evidence-based approaches to treatment. So how do we diagnose it? I mean, 90% of the diagnosis is clinical. I sit and talk to a patient, there's a desk in front, I can't see their feet. Right? If I haven't worked out what's going wrong with them by the time they finish telling me their history, they're nuts. No, I'm joking. They're a little bit mad. So you can get some thickening. There used to be a test that, it still is a test. If you want to work out whether it's the peritendon or the tendon itself, if you palpate the tendon, it'll be painful. If you put it under tension, if it's peritendinitis, then it will still be tender. If it's tendinosis, it's often less painful because you've got a lot of taut fibres around the damage. This will be more of a case of peritendinitis because it's general thickening, whereas you can see some much more nodular thickening. You compare the two, obviously. We can look at x-rays. X-rays are great if you want to assess for spurring. We've already talked about ultrasound with Doppler. Since I've started doing ultrasound myself and looking at patients, this is a patient I had with an insertional tendinopathy with no spurring, and I did a transverse view, and I looked at the shape of that calc. I've never seen that written up anywhere, but that looks like if you tried to put a tendon against that, that could be bloody painful. Right? She's in the early stages. An MRI, obviously. So how about managing it? Well, calf stretches. This is a patient I had. You know, I'll talk a bit about I'm not going to talk just about pressure analysis. And, you know, I met Howie because Ray Anthony told me before one summer school, there's this guy out in the States that's designing his orthotics using pressure studies. He said, it's really good. So I was going to oversee a diabetic program somewhere, and I emailed Howie and said, any chance I could come watch? When I watched, I thought, God, that's got to be the way forward. We've got to be looking. And this just tells me so much. And when I talk to you about how you determine where the dysfunction is, and how you decide whether to do a lateral 4-foot post or a mech dome for a supinated foot, this is how you do it, right? It just tells you something. So this patient, you run him, you video him, heel-toe striking. But when you look inside the shoe, he's got a right calf problem. His right heel's not contacting the ground. I said to him, well, you know, no point having an orthotic because your heel's not even contacting. Do a heel lift. He said, I want to stretch. He went away for 8 weeks, and that's where he got to in 8 weeks. He managed to get his heel down. He still had it. We still gave him heel lifts in the end. But the point was, without looking inside the shoe, we didn't know. We couldn't see anything. So obviously calf stretching is really important, but be careful if they've got an insertional tendinopathy, because if there's spur in there, you get them to stretch their calves, you're really pulling on the emphasis and you might be pushing against the spur, so that can sometimes be painful. Mechanical control includes football. This is Nike Cesium. You can't buy it, but they developed this. This has a 3-degree medial wedge and first-rate facilitation in it. Right? And they did a study in Germany on patients with Achilles tendinopathy, and they had a control and a treatment group, and the treatment group had less pain at the end of the treatment than the non-treatment group just with the training shoe. And when I spoke to LaFortune, who's the researcher, he said, that makes sense to me because it's a sagittal plane problem in the majority of people, and what you're doing, you give them a bit of a heel lift, a bit of control, you facilitate the first MTPJ. I'd expect them to get better. He smiled like this. Right? But you can't buy it because the running shoe stores feel uncomfortable about giving people a shoe that has control built in. Obviously, we can do whatever orthotic control you need. I'm not a fan of saying you've got this condition, you must do this orthotic. What you have to do is diagnose the condition so you know whether it will be responsive to orthotic control or not, or other treatments. Work out what the biomechanical factors are and treat the biomechanical factors. Pronation is not a problem. We pronate for a reason. So find out why they pronate or supinate or don't pronate, because that's what supination is someone who doesn't pronate. Find out why they're doing it, then treat that, then you'll get your treatment right. My slide doesn't include physical therapy, which it should do, because of course, getting your hands in there, doing whatever soft tissue or joint work, whether you're osteopath, chiropractor, physio, whatever, that's all appropriate as well, because if you are tight or you're neurally tight, you've got to get it all mobilised. But eccentric training, the Alfredson group gave us this, and there are 2 different approaches. If you've got central body tendinopathy, you do a training program that drops the heel down, whereas if you've got an insertional problem, you don't let it go lower because it's a problem. And there's good evidence base that this is successful. And furthermore, they've demonstrated that in those patients that respond to the treatment, the neovascularization reduces. So there's an evidence base for it. It doesn't work on everyone, and they get more painful before they get better. So they need to be guided through it. And then there's injection therapy. What they did in Norway was they used polydacronol, which is a local anaesthetic that scleroses, and they sclerosed the vessels to stop them, to destroy them, and they got symptom relief. Because it's hard to come by, what tends to happen in this country is high volume. And there are papers coming out that show that if you do what is a physical stripping of the tendon sheath, basically you stick your needle in right close to the tendon and you inject something like 40 mils of fluid, a bit of local, a little bit of cortisone and lots of saline, and you can see it go, I mean, it strips all the vessels off. And you can see it on the ultrasound because the neovascularization goes. And a high percentage of patients get symptom relief from it. So you know that you can take them through a process. And obviously if you had a rupture in here, you're not going to want to do it, or a big tear. But there's no evidence, any serious evidence, that injecting around the tendon causes a rupture. But everybody thinks it does, so people don't like to do it. But there's no actual evidence. Shockwave therapy. Anybody use it? 1. Right? I have to tell you, there is increasing evidence for plantar fasciitis, Achilles tendinopathy, insertional tendinopathy, that shockwave therapy, and this crossover study shows it nicely, can be effective. The woman I showed you with the irregular calcaneus could not walk for 5 minutes, and we did all the normal biomechanical stuff, no benefit. So I said, okay, I've got access to a shockwave, let's do some shockwave. I treated her. On the first treatment, she walked half an hour. It was like, what? Really? She goes, oh, it's fantastic. And the evidence shows that what you do is you give them 3 treatments over a period of 7 to 10 days distance. If you compare the control group with the treatment group, at 12 weeks, the control group have more pain than the treatment group, or treatment group have less pain. So I say to my patients, this is not an elixir. This kick-starts the healing process. You need to do everything else around it. If you start to think shockwave's the answer, it won't work. And the reason why people do that, you know why? The insurance companies pay obscene amounts of money to do it, and it takes 10 minutes with no risk. The rep came in and he said, yeah, you can code that for. I said, how much? He said, £350 a treatment. What? Each week? And the insurance company, he said, yeah, I laughed. I said, you're joking. They won't pay me that to do a lot of operations. He said, oh, I said to the guy, the hospital director, I said, Andy, you've got to keep an eye on this. People are going to do this for fun because they can earn serious cash out of it, rather than doing it for the right reason. Right? It's part of the treatment process. It works for tendinopathy. I've had patients, I've used it on Achilles tendinopathy. We can do surgery, but loads of people don't. Why? Because surgery for Achilles tendon is not good. It's 50-50. If I had a tendon problem, I'd have to be at the last door to let someone stick a knife in it. Right? It's not good. There are loads of other treatments. Dry needling's become popular. Stick some of your own blood back in, get a bit of plasma out, stick that back in, use some homeopathic injections. There are no controlled studies. Have a look at NICE, for those of you not UK, National Institute for Clinical Excellence, have guidance and stuff. There are no good controlled studies. So people say, yeah, we've had this result, it's positive, we've had that, but there are no good controlled studies, so it's a little bit in the balance. Alfredson goes as far to give an algorithm. What intrigued me was he put cryotherapy in here, somewhere. Oh no, GTM patches, right, to help with pain relief. But I haven't read any of his papers that he's evaluated GTM patches, but he's got it in there. And he's got somewhere down here the mechanical things, looking at the gait and biomechanics. I mean, obviously if someone comes to us, what happens? When do we see patients with Achilles tendinopathy? When everything else has failed. You know what? Why don't you just go and have a word with the podiatrist? Maybe that will help you. You know, when I assess a condition, right, you've got a problem. Right, what's wrong with you? You've got 3 levels of treatment. Level 1, mechanics. That is footwear, orthotics, exercises, physio, whatever it happens to be. That's the mechanics. You've still got pain. Now you can treat the symptoms. Have a tablet, have an injection. Maybe that will help. Now you've still got symptoms, you've got pathology, you deal with the pathology. That's basically it. I think anybody that assesses a patient with a musculoskeletal problem and they haven't considered all the factors, which includes shoes and orthotics, at day 1 and spoken to their patients about it, isn't doing their patient a service. And it's very easy to understand why they do it. Because another great saying, if all you have in your hand is a hammer, the whole world looks like a nail. Think about it. If all you do is give orthotics, everybody pronates. If all you do is treat tight calf muscles, everybody needs flexibility exercises. Right? There isn't one treatment. That's why the evidence base is weak, because there's so much that we can do, and the research studies are poor. There are lots of things that work, and you have to be all-encompassing. So what are conclusions? For Achilles tendinopathy, there are evidence-based treatments available. Right? It's a good condition to treat. You can structure it. And I tell my patients at day 1, with most of the conditions they have, here's your problem, here are all the treatment options, which include surgery. I don't want surgery. I know you don't want surgery, I'm just telling you, you know. Because when the orthotic doesn't work, I give a great example. I have a patient at the moment. In Hackney, we have multi-ethnic culture. And there are definitely cultural levels of pain. So some people, where's it hurt? Here. Oh, great. So I was talking to one of the physios and I said, Pete, you know, this particular, he said, nightmare. He said, I'm with the interpreter, hurt everywhere. So I said to the interpreter, ask her where it doesn't hurt. And the interpreter said, you can't do that. He said, I can. Ask her where it doesn't. You can't ask her where it doesn't hurt. She said to the patient, you do that. You've got an interpreter. And then they go, yes. What? Yes? You just spoke for 10 minutes. Right? Where doesn't it hurt? Here. So she's got 4th, 5th Met cuboid arthritis with a big osteophyte. But she's got multi-pathology. It's not a good joint to operate on. She's had some orthotics. She's sort of done her shoes. She's had a guided injection that, if anything, made her worse. Her son's a GP. Her daughter's a dentist who comes with her. You know, all the gambits. So she comes in. So I go through, start again. Here's all the treatments. We can operate on that. But I have to tell you, that's not a good joint to fuse, which is what we normally do in arthritic joints. So what some people do is take a bit of the joint away and stick a tendon in there. Might help, but you've got rheumatoid arthritis, so another joint could help. We've done all of that. You've got to decide whether you're paying. She goes, I don't want an operation. Fantastic. Good. You know what? You've got to live with the pain. You have to live with the level of pain until such time it becomes bad enough that we have to do something about it. But if you tell the patient, here's your treatment, an orthotic, then when it doesn't work, you have to give people the scope of treatments so that they can jump off the treatment pathway when they want to. Right? And that may mean for some people that they live and modify their activity around the level of pain that they've got. And that's a very important factor. I think our normal, traditional treatment approaches can work. And in terms of orthotics, I think for Achilles tendinopathy, quite often, and a lot of my patients, it's a sagittal problem. So we address that, and I use heel lifts. The eccentric exercise program should be a first line of treatment. Right? The patient should, whether or not you refer. I don't bother taking the patients for it. I'm busy enough. I refer them on to someone else to do it, or I give them the paper and say, here, go away and do it. If you can't do it, I'll refer you to someone who can take you through it. And they can work on everything else. Shockwave therapy and injection therapy, definitely. I have no problems recommending that to patients if they have a resistant case. And as a last resort, they could consider surgery. So I guess if you're a professional, you might consider going down the surgical route. Thank you. Question? 11 minutes?
First time in his life. Any question?
People are hungry. Jenny?
It's actually not a question per se, but I just thought, you mentioned the drugs, but I just thought that everybody should really realise how important it is. It's statins that cause tendon pain. So there's very strong evidence. So if somebody's on cholesterol-lowering medication, the statin will cause Achilles tendinopathy. And the problem is that I suppose death from heart attack is a bit more than Achilles tendinopathy. So whether there's some alternate medication that actually lowers the cholesterol without causing the tendinopathy, I don't know. But do ask that, because you could be scratching your head. And I mean, you will ask, are you, what medication you're on? But if you realise that statins do cause very, very strongly Achilles tendinopathy, then that may be a problem with what you're trying to do with treatment. And we may have to sort of see what alternate things are around. But, it's a bit hard. I suppose your Achilles tendinopathy does go if you do die from your heart attack. So, but... So I just...
you die with your tendinopathy.
That's true. So you die with it, not of it. But it is quite important to realise that. So as you talked about medication...
Yeah, that's good, thanks.